everybody, welcome back. Now I will introduce you Dr. Anterior, and please welcome.
Welcome to the wake up speech. So thank you for being here. Thank you for Mario for inviting me to this multidisciplinary workshop in this magnificent facility. So I'm gonna give you an overview of my approach to periarticular pain. I'm hip surgeon in Balearic Island. I'm also associate professor of anatomy. And well, I'll start with my approach to pain. I'm in a hip unit, so it's very common in Spain that the patient comes referred from the GP and he claims that he's got a pain in his hip. In Spanish hip, we used to say cadera, and the patient used to point in that area, and this is me, and I think this patient's got back pain, and why he referred to me because of hip pain. So that's the question. Why I started to think about this assessment pain. So this is the etymology. So the cadera is correct in Spain. So are the two protruding parts of the iliac crest. So the patient used to summarize his pain in just one word or a few words, and you used to be from common language. We take that words and we try to give a diagnosis. So if I work in a language speak country, the patient would be referred for a pull groin, a kick groin, a lump in the groin. So we've got, as I see, two major biases in pain communication. We still use common language or very simple anatomic language to express topographic information, and we tend to attribute our pain from the first time to a cause. That's the etiology mentality. That's two very important biases in pain assessment. So back pain is essentially a complex and multifaceted experience with many multiple neuroanatomic pathways not yet very well understood. The pain is a biopsychosocial experience, and there are many health professionals involved with many different cultures. So it's very complex to get to express the pain in just one word. So I try to investigate to find out which tools do I have to locate the pain. And this is for example, my hospital pain unit chart. It's more like a police agent stopping you in a breath control. And that's what we are still using. Yes, it's very common. Just a very simple scheme of the body with maybe some dermatomes, and that's it. And well, this is the MAGIP questionnaire. Also, we use very simple schemes. They're new APPs like the chronic pain trackers. They use very simple schemes. Well, there's up here this application, this clinical pattern recognition that goes in the line with what I'm investigating. And well, it's the same scheme, and you've got some possible diagnosis, but this is not validated too. This is oriented more for physiotherapists. And the patients, they figure out their own tools. So this is Antonia, a patient of mine, and she made their own scheme, described the pain very precisely, and even with the activities, because she was aware that just one word was not enough to express the complexity of her pain. And so he made up her own. So I went to literature, pain map, and the first publication was almost 60 years ago in this, and was related to back pain more. and from then on, not much has been published. So most of the publications are deal with back pain, low back pain, but as you see, they're not so new, and they deal more with validation of registering patterns that with diagnosis correlation. The more recent that I found is related to cervical spine, and it seems that it can predict the outcome of cervical disc surgery. So I think it's a breakthrough, and with this simple pattern, with this very simple pattern, they draw these conclusions. They can predict the outcome with this simple pattern. If we go to periarticular pain, there are not many publications, and most in knee. I found more or less these 3 publications, and they only deal with validation of topographical patterns, but they don't find out any diagnostic correlation. And they are still very simple patterns, but they are validated, and the main conclusion is we need additional study to determine whether specific knee pain patterns correlate with this specific pathologic findings. This is also a photographic pattern. This is the most recent one, and there has been even one that has validated these patterns in a digital platform, in an iPad, and that would be the next step. And in other articulation, the only publication that I found is in shoulder, and it's from this author, and the last publication was last year, and it's the first that I found that finds a correlation between a topographical pattern, a very simple topographical pattern, and 4 pain descriptors. And they describe 5 main syndromes, and they find a correlation between these simple pain patterns and descriptors and 5 diagnoses with this algorithm, and they find that there's some correlation, not very accurate, but it's the first publication that I found between pain patterns and diagnosis. There are 5 types. I can give you later the literature, the reference. And this is the first study about shoulder mapping, and the conclusion is that it can be a useful adjunct to the clinical assessment and as a very useful tool for research. So the results, and so that's with this on mind. I went to my personal approach in orthopedic surgery. We're used to this alphanumeric. We got the same problem with the bones. Where's the fracture? With the proximal part of the tibia. So the AO International, there's a Swiss association. They developed this alphanumeric system, and that's what we used for publication, not for common language, but for publication. And it's alphanumeric, and you can make numeric research with this, and that's the main breakthrough that you can quantize. It's a quantitative or semi-quantitative method. So, I thought about my knowledge of design, and we got the orthogonal projection. So I made a scheme of the hip, and you can apply this to any more or less to any part of the anatomy. And in the hip, that's the main area of interest. There are 3 views: front, lateral, and posterior view. I made a grid 3 by 3, and in the corners it's common, so it would be only 21 squares all over. And you can apply it also to the knee or to the shoulder, to any joint. It can be applied. Of course, I don't have the time to validate this model, and I use this stepwise approach. I do a pain mapping and not just rely on one word, on as simple. I do a pain mapping. I do a direct exploration of looking for what there are many maneuvers I don't do. I do a direct exploration. We can do afterwards a complementary image studies, and we got the echography there as a very useful tool. I've got a first diagnostic impression, and well, and then I can plan a treatment, and we got the ultrasound as a very useful tool for that. And then we can have a much more definitive diagnosis, because we've done an ultrasound guided procedure, and we know exactly where we put the local anesthetic. And then we have to measure the outcome and to go to our pain to see if there's a correlation with the pain mapping that we've had. So on the main pain, well, we'll see later in the lab where what can we do with the ultrasound guided procedures. And we got in the hip we got three main patterns: the anterior pain pattern in the groin would be in English, lateral pain pattern, and posterior pain pattern. In the anterior pain patterns, most of the pain is related to joint, and we'll see later what's a new described pathology. That's the femoral acetabular impingement. We got also the psoas tendon pathology, the more lateral, and there you see the hip is around here. So pain from the hip will be in the B row, maybe down. But there are many irradiations there, but at least you can have an alphanumeric description of where's the pain. You've got the symphysis bonis here, you got the anterior iliac spine over there, and there are not so many squares. It's not so complicated. And we also, for example, meningeal peristhetica, osteopathy. There are many pathologies. It's a very complex anatomic region. The hip joint is got at least four sources of innervation. In the anterior part, femoral obturator, and in the posterior and superior gluteal nerves, it's sciatic nerve and the branches to the quadratus femoris. And well, this Newton's law, if you don't remember, is that the nerves that innervate the joint also innervate the muscles that move it, and the skin that covers the insertion of those muscles. So that's what explains the very complex pain pattern of the hip, because you've got four branches and all the and you've got many muscles involved. And well, this is a publication about the capsular innervation. Most of the terminal endings, the sensitive areas, and in the anterior part of the joint. That's what the pain pattern from the hip is usually related to the anterior part of the thigh in the femoral and obturator distribution. Well, and going through the most common pathology of the hip, you've got the femoral acetabular impingement. That is the main cause of pain and osteoarthritis in the young adult, and it's not very well known by the people that is not in this field, and it's produced by an impingement of the neck of the femur, inflection, adduction, and internal rotation against the labrum and acetabular ring. And I'll show you the usual mechanism. So, okay. Okay, so this is the usual mechanism. So when the neck of the femur and this what we call the cam is that humpback, and it impinges against the rim, and that's the cause of the osteoarthritis in the hip, and so the labrum is also very densely innervated, and as you see, the impingement takes place in the anterior and posterior superior quadrants, That's why the pain in this pathology is referred to the anterior superior, and is produced by this maneuver, by the impingement test, that is to reproduce that impingement. That impingement is flexion, is deep flexion, adduction, and internal rotation. So what's the clinical presentation? It's mostly groin pain, inguinal pain, but we can also have some posterior pain because of the posterior innervation of the capsule. You may have also clicks, sensations of failure, and is related to that position. Is maximal flexion, and well, the activities that reproduce that maneuver. And just remember, because this is very simple, it's a very simple maneuver, and well, the first movement that is affected is the internal rotation. If you see that a patient has not internal rotation, you may be very sure that he's got a hip joint pathology. After, well, just over the hip capsule, we've got the psoas, and you've got also very common pathology of the psoas, what we call psoas tendonitis, and the internal snapping. We got two snappings, internal and external, and internal snapping is produced by the rubbing of the psoas against the iliopectineal eminence with twisting movements and rotation movements of the hip. It can be painful or not. I've got an internal snapping. That's very common, and it's very common because the anatomy of the tendon is very complex. It's got usually 3 tendons. You've got also here a muscle bundle from the iliac belly. You've got also 2 bursas, and with the flexor extension, the iliac muscles get it down the psoas tendon. So it's very common to have a snapping of the psoas. It is not necessarily pathologic, but you can have iliopsoas bursitis because of that snapping. And it's very common in my practice, related to prosthetic cap overhanging, and that's a very common cause of pain. You've got patients with a retroverted cap. This is the cap of a hip prosthesis, and you see that you should be in line with the rim, anterior rim of the acetabulum. And if you put the cap retroverted, it's just down the psoas. That's gonna be painful for sure. And in this case, well, it's methyl against tendon. It usually wins methyl. Here is the reason of the snapping. You see that the psoas does a very tight turn over the eminence. It's a 90 degrees turn, and the psoas is a very strong muscle. So when it pulls, the iliac muscle takes down the tendon of the psoas, and you got the snapping. But when there's a prosthesis, it's usually very painful. It's a very common source of pain. You got in the anterior part of the hip. You got also rectus femoris pathology, but it's more lateral. In the anterior inferior iliac spine. You've got 2 tendons, the direct and reflex. It's usually more an overuse pathology, and is related to kicking, sports, and in young patients you can have. It's very common, the avulsion of the anterior iliac spine, and it's usually treated conservatively. And well, another very common cause of pain in the anterior thigh is the paresthetic meralgia caused by the impingement of the encroachment of the lateral cutaneous nerve of the thigh under the inguinal ligament, more or less one finger breadth, medial and distal to the anterior iliac spine, anterior superior iliac spine, is related with dysesthesias, but it's not so difficult to to describe. And in this region is very useful the ultra guide injection, because we're dealing with very deep structures and very deep structure and difficult to explore. So we've got very easy procedures like the intra-articular injections. We can, if we see a paralabral cyst related to a labral detachment, we can also puncture that paralabral cyst. We can do the infiltration of the iliopsoas, rectus femoris, the adductor longus, and we can access to all the nerves in the anterior part of the thigh. But we'll do this in the lab. On the nerve. And the lateral pain pattern is the most common one. Most of the patients refer to a hip surgeon, properly refer to a hip surgeon. They got a lateral pain pattern. And in this case, the two main causes are what is called the greater trochanteric pain syndrome, and related to the gluteal muscles and bursae, and the sternal the extraarticular snapping or snapping related to the iliotibial tract. This is so common that in some studies, even a quarter of the population has suffered from that in some moment of their life. And it's very simple to elicit and to describe. It's just pain on palpation, tenderness in the trochanteric region, and the question that I always do to my patients, if they can sleep on their side. And if they say that they can't sleep on their side, I know, I don't need more information. And in the echography, it's not so common to find a bursitis. So if you find a patient with greater trochanteric pain and you do an ultrasonography and you don't find any liquid, that's common. And so don't be messed up by that. And we got three bursas. We got the trochanteric bursa, that is the biggest one, that is down under the iliotibial tract. But we got also a bursa under the gluteus medius, under the lateral section of the gluteus medius, in the upper part of the greater trochanter. And we've also another bursa under the gluteus minimus, that is in the most anterior facets of the trochanter. So this is the most common source of pain, but we can have also bursitis in these two other locations, and there's no other way to get there but with the ultrasounds. So this would be the greater trochanter bursa, but you've got also here the bursa under the gluteus medius. The clinical examination is very easy. You feel tenderness in the posterior, usually very precise, and in the posterior superior angle of the greater troch, and also on the flexion abduction, external rotation maneuvers is useful. But just with palpation, you can find a very tender point in the posterior superior angle of the greater troch, that is the most outward part of the greater troch. You can have also pain against abduction, and if you go, and you may have some kind of pathology of tendons. The hip, the gluteal tendons are like the calf of the hip, instead of the shoulder. And when you've got a snapping, you can have a snapping if you do the bicycle, you do flexor extension, you do the bicycle on the lateral sides, you can feel a snapping of the iliotibial tract, and that's what we call external snapping. And it is not necessarily pathologic, but it may be quite bothersome, and especially very common in women. And you have to. Sometimes it's not so easy to reproduce. It's when you pass from extension to flexion, and you can see it with the ultrasounds very, very easily. And in the lateral region of the hip, we can infiltrate all the bursas. The greater troch is very easy inject, to infiltrate blindly, but not the rest. And in case of Morel-Lavallée effusions under the, usually post-traumatic, under the fascia lata, we can evacuate it very precisely also. That's what we'll try this later. This is in a short axis. You can do it in the long axis also, and it would be the evacuation of Morel-Lavallée. And well, and the last one would be the posterior pain pattern. And in this posterior region of the hip is more related to back pain, sacroiliac joint, and is much more complex and not very well understood pain pattern. And so it's more related to facet, joint pain, cluneal nerves, sacroiliac pain in the more upper quadrants. And we got what is now called the deep gluteal syndrome, before known like piriformis syndrome. Now we call it deep gluteal syndrome because there are more structures involved than just the piriformis. We can have the posterior hip pain, as we've seen, because of the sensory nerve endings in the posterior capsule. We got a new described syndrome of ischiofemoral impingement between the lesser troch and the ischial tuberosity, and we got down the hamstring tendonitis. So it's a very complex region, and here is very useful to use the ultrasonography for diagnosis and treatment. But as I've told you, it's more related to pain, to back pain, sacroiliac pain, and I think that you yesterday deal with this syndrome. Huh? And well, now instead of piriformis syndrome, we call it deep gluteal syndrome. It's very common in low back pain, and it usually irradiates. It's got a sciatic irradiation, and well, you got specific signs for the piriformis tendon. You know, this exploration. But recently, some Spanish authors, Dr. Pérez Caro, they describe based on MRI findings, these fibrous bands around the sciatic nerve that may explain this kind of pain instead of just the piriformis. Ultrasonography, but piriformis injection is difficult, and these bands are impossible to find with ultrasonography. You have to do an MRI, but at least you can inject around the sciatic nerve. Well, yes, the last one would be very common pathology of the hamstrings insertion in the ischial tuberosity and the ischial bursitis, and well, it's a very common pain related to running athletes and related to sitting, and also we can inject this area with ultrasonography very safely. So, well, that will be what you can do. So yes, I'll finish. So my take-home message is that pain is still the main reason for consultation overall in medicine, not just in a pain unit, of course, and it's the main cause of interference with quality of life. The pain of pattern has got the greatest diagnosis specificity, even that imaging test. We've got the MRI, we've got very modern imaging tests, but still the pain pattern is the most diagnostic specific. He's got the most diagnostic specificity. The patient usually help us pointing to an anatomical superficial region, so we have to record that information, and we need to develop validated and reproducible measurement tools that record that topographical information in the most accurate way. So thank you for your attention, and don't get lost in translation.
Do you have any questions? Okay, thank you again.